Rahman Rahim. It's my great pleasure, indeed, to express my dear gratitude to accept my participation. And really, my colleague Shaima and my colleague Rana simplify this talk when talking about congenital heart disease and role of MRI and details and techniques of MRI. So we are starting with a tiny heart, which is a fetal heart. To start its imaging and how to delineate or implement the imaging of MRI of the congenital heart disease, but in fetal life. But without doubt, the rule of ultrasound as a first line of screening is mandatory. It's firmly established, cannot be a substitute with MRI. However, MRI becoming increasingly important because it's rapidly increasing awareness of it and its safety. So advantage of MRI over ultrasound, it may be visualized of all fetus with no significant limitation with maternal or fetal obstacles, visualization of the brain of the fetus with no restriction of ossified skull. Also, it can distinguish individual fetal structure altogether. Not dependent, it's not operator dependent, it's non-invasive diagnostic examination and not associated with any negative side effect reported until now. MRI could be done in any stage of pregnancy. However, we are preferred to be in late trimester, above 28 weeks of gestation, to overcome the risk of moving excess motion of the fetus. So with the indication of MRI, we can see the large list of indication of fetal MRI. I started with the fetal MRI as a whole, and we will go to the fetal cardiac MRI. So we can see how many, that's the list of fetal MRI, it's requested in any specific lesions of the brain, spine, thorax, GIT, also come in surgery assessment before fetal surgery. So to prepare the mother, the fetal MRI done in 1.5 Tesla superconducting MRI using normal torso surface coil, which is using in abdominal MRI. Ideal protocol take around from 30 to 45 minutes. The main precautions to reduce the motion of fetus and to calm the mother is come in early morning with at least 4 hours of fasting. Make sure that it's empty her bladder because we'll stay for 40 minutes on recombinant position. The mother are requested either lying on supine position or lateral decubitus, whatever she prefer. The technique of MRI as a whole, will be the same schedule when requesting fetal MRI, which is most widely used sequences in fetal imaging are T2 single shot fast spin echo, which is maybe the same name of white blood images in cardiac MRI. It's based on single slide acquisition. So if the baby moved in any time, so it's one slice acquisition failure, so we don't need to repeat the sequence as a whole. In contrary, T1 weighted images is dependent on gradient echo, which is considered as slices acquired simultaneously. So we cannot see the images until the end of the sequence. So any movement of the fetus all through 2 minutes or 1.5 minutes of sequence will obstacle all motion artifact of all sequences and need to repeat the whole sequence again. As regard fetal MRI, we used mainly balanced steady-state free precision as we do in pediatric age and adult age, because the balanced steady-state free precision is safer in fetal MRI. In advanced MR technique, now diffusion-weighted images, DTI, MR spectroscopy in the fetal brain, as well as it's prognostic information for the brain function. And we will see the images next slices. This is an parameter for basic sequences of fetal MRI. We're starting with multiplanar scout for the fetuses and shift into T1 weighted images to delineate the hyper-intense organs. It's become hyper-intense in T1 weighted images like thyroid gland, liver, and meconium. Then we're starting in anatomical sequences, starting with slices of the fetal head. If there is abnormality in fetal head, we can do a diffusion weighted images, ADC, fractional anisotropy, and spectroscopy to measure the normal value of all choline, creatinine, lactate. Also, if there is a suspicion of suspected abnormality in skeletal system, so we want to see the overall appearance of the baby. So we will give him a 2 to 3 minute sequence and making a sequence like thick slab or dynamic sequence to see an overall movement pattern if there is abnormality in skeletal system. So we can here delineate the difference between T1 weighted images and T2 weighted images in hyper-intense organs of T1 weighted images. Also, a balanced FFIE as we see in any vascular and cardiac system. So to summarize, start with initial localization, must be obtained in 3 orthogonal plane. Then fetal organ of interest have to be center of the coil, centered in the image, and we can adjust the field of view either to decrease or increase. However, we want to see fetuses or maternal dimension. About general limitation of fetal MRI is high cost, limited availability. FDA still approved, and that's gadolinium-based contrast has not approved until now that is safe in pregnancy, and we didn't use it until now. So we can say, to summarize fetal MRI, to shift into fetal cardiac MRI, that MRI is evaluating and interpret a systemic oriented approach starting from the brain till the extremities. So sagittal view is highly needed in identifying placental location, mid-sagittal view for facial profile and head circumference, axial plane for abdominal circumference, hand and both kidneys, and coronal view for upper limb and both orbits. Now we start in the fetal cardiac MRI. It is a study for fetal heart along body and cardiac planes, which is potential value to detecting cardiac and extracardiac abnormality. So we want to delineate or to highlight the advantage of MRI over fetal echo. Its performance, as we said before, it's between 24 to 39 weeks gestation. Also, the patient has to lie in supine and lateral decubitus. It could be combined with fetal MRI protocol, and could be occurred only fetal cardiac MRI, starting with survey with 3 orthogonal planes, and then starting with maternal plane, axial, coronal, and sagittal, and shifting directly into black blood, white blood, cine images of the heart, and dynamic single balanced, as we said before. Important point that each new acquisition must be dependent immediately into the immediately previous acquisition, because if there's a previous acquisition have a motion artifact, will be subsequently artifacted sequence, and additional images are designed. However, if they see an accidental finding. So as we do with an adult and with a child, starting with an axial localizer, obtaining a mid-sagittal view, and then from mid-sagittal view getting a coronal plane, in which we can get a long axis, then short axis, and finally we get the sure 4-chamber and 2-chamber view. So we can see in a difference, or the comparative images between fetal echo and fetal cardiac MRI, how we can see in an axial plane the interventricular septum, both atrium and both ventricle, also left ventricular outflow tract, right ventricular outflow tract, and bifurcation of main pulmonary artery. Also in upward level 3 vessel view, how can see that the fetal cardiac MRI is highly informative. In coronal plane, we can see cardiac apex, left ventricular outflow tract, inflow systemic vein, either hepatic veins or systemic veins. Also, the main bronchus are highly delineated with its high intensity from amniotic fluid. In sagittal view, we can see aortic arch and its branches and systemic inflow veins. Okay, we can analysis of a fetal MRI. And assessment of functional assessment of cardiac MRI using either cine or dynamic. But because the fetus heart rate is between 120 and 160, so it's we need a special gating, fetal cardiac gating machine, either software and hardware, to detect that this QRS peak of ECG of the fetus, and then we're doing a functional assessment. But until now, and I will see you in next slides, this software and hardware, how it works. But now we are stand on the just anatomical assessment, and to see how in long axis and short axis, how an end systole and end diastole differences of ventricular size, and how the numerical function assessment could be getting when we see the getting this highly ended one of top-notch machines are used for smart synchronization and to getting the fetal cardiac MRI, ECG, and it's very simple machine. Just to put this hardware on the belly of the mother and to get an ECG of the fetus, and starting imaging of cardiac MRI with all its functional assessment. As we will see ECG of the fetus, we can see cine images very clearly. Also, we can, in all congenital heart disease could be easily detected and easily diagnosed, like aortic coarctation. Also, the flow, 2D flow images could be happened with the fetus heart. 4D flow post-processing, as we do with the adult heart. With all functional assessment. Overriding aorta, all our congenital heart disease could be easily diagnosed. Double aortic arch, aortic coarctation, AVSD, diaphragmatic hernia, detransposition of great arteries, type of VSDs and numbers and sizes, like we do with an adult, exactly. And this software and hardware have an MRI integration with all type of machines, either fully integrated or with wireless integration. So I would like to express 4 cases of cardiac MRI or fetal cardiac MRI done in Ain Shams University. First one is 27 years prime gravida with non-consanguinity. Fetal echo shows hypoplastic left heart syndrome, query anomalous pulmonary venous return, and query aortic arch coarctation versus interruption. Cardiac MRI revealed hypoplastic left heart syndrome, normal pulmonary venous return, type B interrupted aortic arch. Postnatal echo, which is a standard study revealed confirmation of cardiac MRI finding, and was a type B interrupted aortic arch. Second case, it was a 20-year-old female with previous history of renal congenital anomaly in previous baby. Echo revealed a mild effusion, muscular VSD, and hypoplastic right ventricle with severe mitral regurg. Cardiac MRI shows moderate effusion. The MRI can detect additional apical VSD with 2 millimeter diameter and normal right ventricular size. Postnatal echo revealed normal size right ventricle, and this case was diagnosed as resolving myocarditis. Case 3 was 24 years prime gravida with in vitro fertilization. Fetal echo revealed mesocardia with ectopia cordis. Cardiac MRI revealed associated diaphragmatic hernia and chest wall defect, liver herniation. It's time. I can complete for 1 minute, or I will stop.
Just shift to the conclusion.
Conclusion? Okay. In conclusion, fetal cardiac MRI as an adjunct to fetal echocardiography may provide valuable information that could add to the prenatal diagnosis and evaluation of cardiac and most of extracardiac anomaly. To take a home message, MRI have an excellent detailed visualization of fetuses in utero in all its systems, and fetal MRI useful in recognition of developing fetal anomaly and facilitate management of decision and guide therapy, particularly when fetal surgery is considered. Thank you.
Thank you very much, Dr. Hend. I think we have to close our session as fast as possible. We are 15 minutes late for the next body imaging session. I see everybody is here. Thank you, everyone who was with us for the cardiac session. I would like also to thank all our professor with me this morning, and thank you very much.